Hello, everybody. We'll be starting, I think it's 7 p.m. Central right now. So welcome, everybody. Thank you so much for joining me today. I will be attempting today to go through the essentials of testosterone therapy in men. This is only part one of 3 parts of an entire lecture that goes through the basics and side effect management and different treatment options. Today we'll be speaking about what low testosterone means, the health risks of having low testosterone, the different diagnostic tests, and the different treatment options and how to use them. I will be giving another lecture probably in 2 weeks to cover side effect management and other issues. So why don't we go ahead and start since it seems like people are already here. So I'm the founder of ExcelMale.com, DiscountedLabs.com, and also a co-founder of ClinicOptimizers.com. I'll be speaking about what those 3 different companies do. But first, before we proceed, I'd like to make sure that everyone understands that this information is not intended to replace attention or the advice of a physician or other healthcare professional. Anyone who wishes to embark on a dietary, drug, exercise, hormone, or lifestyle change intended to prevent or treat a specific disease or condition should first consult with and seek clearance from a qualified healthcare professional. Today, I'll be speaking basically about the knowledge I have gathered through my 30 years of using testosterone replacement therapy. I'm a treatment educator, I'm a research advocate, and I wrote the book Testosterone, a Man's Guide, which is, I'll be providing a link today on how to download it for free. So why don't we proceed some more? So the topics today, this is, as I said, part one of several parts. We'll be going through what testosterone deficiency means in men and the reasons, the causes, the clinical presentations, the diagnosis and initial evaluation of male hypogonadism. Also, I'll be covering the different treatment options, benefits versus potential risks, and how to monitor patients on the different treatments. As I said before, I will not be covering testosterone side effect management today. That'll be I'm leaving that for another lecture, which will probably happen in 2 weeks. Otherwise, we'll probably be here more than an hour and a half today. So I'd like to first start with a free offer. If you go through this link, offers.testosteronewisdom.com, you can download my book, Testosterone, a Man's Guide, which basically has all the details I speak about today. It's a book that was written a few years ago, but I still think is valid as we cover the topics today. There's also a code there that you will get if you're in the United States to get a discount on compounded medications. So take advantage of that and forward that link to any of your friends. Something else I wanted to mention before I forget is that this video, the video of this lecture, will be posted on the ExcelMale YouTube channel. So if you, for some reason, couldn't watch it all the way, or you like to forward it to your doctor or a friend, it'll be posted by tomorrow on the ExcelMale YouTube channel. And a little bit more self-promotion, and I apologize, I'm doing the promotional part at the beginning so that I get your attention before. And these are all resources anyways, free resources to learn more about testosterone. ExcelMale.com is a site, a forum site that I created about four years ago. And right now we have almost 18,000 members. There are lots of few doctors there answering questions and a bunch of really educated men that have used testosterone for a while. So you can get answers to your questions. We also send newsletters. We do interviews with different doctors and experts. The guys also post reviews on clinics and different treatments, etc. And we also can refer to clinics if you're looking for one. You can also download a free ebook once you register. And yeah, this looks pretty busy, right? So these are all the folders that we have on ExcelMale.com, so that you know that everything I'll be speaking today, you can refer back to ExcelMale. So we have basically testosterone basics and questions, how to prevent and reverse side effects, how to use, for instance, Clomid for fertility when testosterone is not enough. And I like to make sure that people understand that testosterone is not a magic cure for libido and erectile dysfunction, etc. There are cases where patients do not respond as well as expected. So we speak about the options for those patients. People post blood test results on the blood test discussion folder. That's actually pretty useful, because it's a great way to get input from other people and even doctors on the site. We post different studies that pop up almost every day on the miscellaneous studies, resources and suppliers, what you can buy, not only supplements, but different clinics, and et cetera, et cetera. We also have a folder where you can actually ask directly doctors and experts that we have on the site. And this is all free, by the way. We have expert interviews, which are videos and written interviews that I've done with different researchers, workout, routines, health, wellness information, nutrition, and supplements. We also have a folder right here on the right-hand side, general peptide use. Those are growth hormone releasing hormones, which people seem to be very interested about. We have a section on androgens for chronic illnesses and injury, the use of anabolic agents for wasting disease, etc. HRT in women, even though this site is called ExcelMale, a lot of men and women come to the site to get information about women and hormones. And we also have folders, since I'm Spanish speaking, I'm from Venezuela, as you can tell from my accent. So we have a folder for Spanish speakers also. And last but not least, you can go through reviews of doctors, clinics, compounding pharmacies, supplements, blood testing companies, books, et cetera, et cetera. So just wanted to let you know what's available on ExcelMale. I'm very proud of the guys that are on the site. I have great moderators, so nobody gets abused, and everything is pretty much in control of any potential misbehaviors that you see a lot online nowadays. Another company that I'm on is discounted.labs.com. I created a company that provides affordable blood testing in most US states, except a few states on the Northeast. And I'm very happy to say that I probably provide one of the best prices out there. You can actually order, if you go to discounted.labs.com, you can order your own test and go to the closest LabCorp location without having to see a doctor. We email the results within 5 to 7 business days, depending on the blood test that you are getting. We also created an app that you can download for free from the App Store or Google Play. It's called TRT Analyzer. I think we've had more than 8,000 downloads so far. And this is a really interesting app that you can use to really track how well you're doing every day with this, when it comes to energy levels, libido, erectile function, mood, etc. And the good thing about this is that you can plot every single variable and either print it or email it to for your doctor to see. Especially if you change dosages or start something new, there's actually records on the app where you can actually add when you change a dose, testosterone or other products, and also how you feel day to day. We send an alert late in the evening for you to remember to put in your different scores on how you feel. So I'm very proud of that app. It's also free, and as I said, creating a lot of resources for people that are interested in learning more and also tracking their health. As we go on in this world, now we're trying to take charge of our health more and more. And that's why you're actually watching this webinar. We have a bunch of resources here. Another one of the sites that we created, I'm very also proud of it, is called My Health Graphs. That actually plots your blood test results. Right now it's a manual process. We are actually proceeding to make it automatic once we get some software upgrades in which if you have a PDF blood test form, you may actually be able to read it and input it in a graphic format. But go ahead and visit the site and use it up, and let me know by sending us a comment on ExcelMale on how you like it or dislike it, because we're still obviously trying to get input from users. So we're going to start. Enough of promotion, but as I said, those are free resources that if I don't do it at the beginning, I'll forget at the end, and or you guys will probably be tired of all my talking, because I do have a lot of information to cover today. So we're going to go through the basics, okay? And this is really basic. I actually deleted probably half of the slides this morning because it was getting too long. So you please forgive me sometimes for the simplicity of the information I'm providing. You will be able, you or your doctor, be able to get more details and more detailed presentations soon on clinicoptimizers.com, which is a company that I created with a friend of mine to provide education to physicians that want to start, treating men and women with hormones, and also, weight loss options, etc. So anyways, a change of hormones as we age. As you can tell, these are different hormones: estrogen, thyroid, progesterone, insulin, testosterone, cortisol, growth hormone. And this is not only male related, but also females. And most hormones, as you can tell, go down with age, except insulin and cortisol. Insulin, we become more and more insulin resistant, and our cortisol, which is an inflammatory hormone and stress hormone, also increases. So, which also, those two trends of increased insulin and cortisol also makes us gain more weight, more fat, get more inflammation, and more chronic illnesses that are related to aging. So today I'm only going to focus on one of them, testosterone. I will have a lecture on each one of these hormones for you guys to watch. So stay tuned. Okay, next one. So testosterone, the target organs. Testosterone is an androgenic hormone. The world, when you say testosterone, equates that hormone to males. And the fact is that not only men have it, but also women. Women have it at 1/10 of concentration that men have in their bloodstream. But in the target organs are pretty much common, except obviously for the penile organ. When it comes to effects of testosterone. So testosterone has effects on hair growth, balding, sebum production that causes sometimes acne. Liver, actually, it improves, promotes the synthesis of proteins in the liver. When it comes to male sexual organs, it's responsible for penile growth, spermatogenesis, which is a production of sperm, prostate growth and function. In the brain, it actually affects libido and mood. In the muscle, it increases strength and muscle volume. In the kidneys, it actually stimulates the production, I'm sorry, there's a misspelling there, stimulates production of red blood cells. In the bone marrow, it stimulates of stem cells. And bone, it accelerates the linear growth closure in growing boys and girls. So it is also obviously associated with bone density. And what are the effects of having low testosterone? And I'll go through the different slides and coming up on explaining what low testosterone means and the ranges, etc. But one of the effects is sexual dysfunction or lack of interest in sex, some erectile dysfunction, decrease of sense of well-being, increase irritation or moodiness, decrease red blood cells to the point that somebody can become anemic, decrease bone mineral density, decrease lean body mass, muscle strength, and increase in fat mass. So, and as you can tell, a lot of all of them could be associated with aging, but in fact is that normalizing testosterone blood levels can reverse most of these effects. And this is where most of the controversy and discussion occurs, even in 2018, when it comes to defining what's normal testosterone, what are the normal ranges. And believe it or not, it not only depends on the guidelines, committees and medical groups, but also on the different lab companies, you know, like LabQuest and, I'm sorry, LabCorp and Quest and other lab companies have different ranges, believe it or not, because they have, they gather that data from their own database on the spread of testosterone in men that actually use, and women that use their companies. But in general, it's probably safe to say that the total testosterone, I'll explain what that means, total and free testosterone, that's coming up. They range anywhere from 350 to 1100 in men and from 10 to 50 nanograms per deciliter. By the way, these are nanograms per deciliter. For people watching the webinar from outside the United States, the units are different. Usually we talk about micromolars per, you know, per liter or other units like that. So I apologize for that, but these are units used in the States. So the symptoms of low testosterone, as I said, fatigue, low or lack of sex drive, poor appetite, loss of muscle mass and strength, depression, and others. The effect of age on testosterone, age-related decline begins around 30 to 40 years of age, and approximately 1.2% testosterone is lost every year. And obviously that loss can be accelerated by different factors that I'll be covering soon. The average testosterone of a man 75 years of age compared to a younger man of 25 years of age, total is about 35%, and bioavailable, I'll speak about what bioavailable means, is 50%. However, many men in the 7th or 8th decade have normal testosterone levels. So this is not 100% of a rule for everybody. Some men are healthy enough or lucky enough to not have testosterone deficiency when they grow older. Excuse me. And also something that we forget sometimes is that the circadian rhythm actually promotes the production of most hormones at night. And the testosterone peaks early in the morning, around 4 to 6 a.m. And it peaks both in men and older men and younger men. But as you can tell in this graph, younger men obviously have higher levels and a higher peak. The difference between older, the higher, but effects are blunted by age. So you can tell in the older men, there's not as much of a peak and it's more of a constant blood level throughout the day. And that happens in most aging men. So what testosterone level is defined as low? And this is another point of controversy and discussion. I mean, and I don't think we're ever going to have groups, medical groups, agree. Although we're getting closer, as you can tell on this table, but these are different medical groups. The European Academy of Andrology, the European Association of Urology, the International Society of Andrology, the International Society for the Study of the Aging Male, and the Endocrine Society. So the first three agree, and that was guidelines of 2009, that anything under 350 nanograms per deciliter, or for guys outside the United States, is 12.1 nanomolars per liter, and free testosterone less than 65 picograms per milliliters. The TES, which is Endocrine Society, I think they just posted a new guidelines where it's more or less the same value, 300. And they say, and disagreement here too. So on the Europeans, 350, and believe it or not, there is a group of experts that got together in 2014. These are high prescribers. Doctors have a lot of experience that agreed that anything under 400 nanograms is considered low. So there's no agreement. Insurance companies vary too when it comes to approval of testosterone therapies. Most of them are going now by 300 to 350. You also have to have the symptoms, and obviously a blood test that proves that. For clinics that do not take insurance, cash-based clinics, they tend to be a little bit more, flexible when it comes to testosterone blood levels, up to 500 nanograms if you have symptoms of low testosterone. So it depends, obviously, whether or not you're going to be getting products that are paid by your insurance company, or if you're going to be using, for instance, a compounding pharmacy. And I'll be explaining what compounding pharmacies do and what different changes in that industry are as we speak. I also reviewed a few studies. I didn't write the references here because there are too many, but you can go to excelmale.com. I have this information references. But these are different studies that have actually linked different levels of testosterone and risks of different pathologies or diseases or issues or health issues. Less than 450. This study linked that to a risk of increased metabolic syndrome, which is increase in fat mass, waist circumference, low HDL, high triglycerides, etc. Less than 400 in another study linked to venous leakage, which is internal penile damage that affects erectile function. Less than 350, a study actually linked that to all-cause death risk and anemia risk. Less than 300, lower libido, weight gain, and diabetes risk increased. Less than 300, increased risk of fractures, memory-related issues, the depression risk increases. Less than 250, in another study, increased arterial plaque and decreased sleep quality. Less than 235 in another study, hardening of the arteries, and less than 200, decrease in morning erections, and less than 150 increase inflammation. So as you can tell, 300 or so, 350, 300, it's kind of a midpoint in all this data. And so it actually makes sense so far. What the guidelines have been saying is not far off from what studies are showing when it comes to increased risks of different health issues. Not going to go through this whole steroid hormone pathway, but I wanted to show this to remind everybody that really the mother of all hormones is cholesterol. Without cholesterol, we would not be able to make sex hormones or even cortisol. And there's a cascade, and obviously the cascade, at the end of the cascade here on the right-hand side, you see the androgenic hormones, DHEA, androstenedione, testosterone, which aromatizes to estradiol, converts into estrone and estriol. So I'll be speaking about the estrogens in the next lecture. Today, I'll be concentrating mostly about testosterone and not on the aromatization of testosterone into estrogen. And this is how, this is what we call the HPTA, or the hypothalamic pituitary testicular orgonadal axis. And it's another cascade, basically. The hypothalamus, which is a gland, obviously, in the brain sends gonadotropin releasing hormone, a signal to the pituitary gland, and the pituitary gland sends two signals to the testicles or the ovaries, by the way. This is a picture of testicles, but really women have the same kind of HPTA. The pituitary gland sends luteinizing hormone and follicle stimulating hormone to the testicles to basically make them produce testosterone and sperm. As testosterone goes up, there's a feedback loop that slows down the upstream signals. So what happens when we inject testosterone or use a gel or different options, the body senses that there's an external source of testosterone and basically sends a feedback to the pituitary hypothalamus to stop testosterone production. So that's the first thing that people need to understand, that if you're diagnosed with low testosterone, you have the symptoms, and the doctor prescribes you a therapy, an option, you will be very soon shutting down your own production of testosterone. You're going to be replacing your testosterone that your body was producing, and hopefully increase it to a more healthy level. But when you stop, if you stop, this HPTA axis will remain shut down for a while. It takes, and nobody really can predict, depending on age, depending on exposure, but it could be weeks or months before you regain your baseline production of testosterone. And you will, basically, if you were low testosterone to start with, you will remain, hypogonadal. On the right-hand side, you can see the fractions of testosterone once it's produced. There's the free testosterone, you see the free T's, about 2% of the total testosterone. The green side of the pie on the left-hand side is albumin-bound testosterone, is testosterone that is bound to albumin. Albumin releases it as we need it in the body. And the right-hand side, you see sex hormone binding globulin bound testosterone, which is, believe it or not, is the majority of testosterone, and is bound very strongly and is not really allowed to be used in the body. It's a control mechanism. Our bodies don't really like a lot of free testosterone because there are consequences to that. I'll be speaking in the next lecture about the risks of having too much testosterone in your blood. But there are now studies that are showing that there is a role for sex hormone binding globulin to transport and act on receptors all over the body. So it's not really an evil hormone. There's nothing in the body that is evil when it comes to hormones, even though some men think estrogen or in men has no role, when in fact is we need estrogen in males as women need testosterone in their bodies too. So only 2% is free testosterone and 98% is bound to albumin and sex hormone binding globulin. And this is another graph that shows as we age, sex hormone binding globulin tends to go up and total and free testosterone go down. So that's another issue when it comes to aging, where we have less and less free testosterone due to the increased sex hormone binding globulin. And this is another very controversial issue. People are obsessed with finding ways to decrease their sex hormone binding globulin. And there are really no healthy ways to do that. Actually, leaner people that eat healthy tend to have higher sex hormone binding globulin than people with diabetes, for instance. So there's a lot of confusion on especially on men that are obsessed with increasing their free testosterone portion. And their conditions are associated with increased sex hormone binding globulin, like aging and cirrhosis of the liver, hyperthyroidism, use of anticonvulsants, use of estrogens. HIV has been also known to increase sex hormone binding globulin. There are conditions that are associated with decreased sex hormone binding globulin, obesity, kidney disorders, low thyroid, use of certain medications like glucocorticoids, progestins, and anabolic steroids. Acromegaly, the excess of production of growth hormone, and diabetes. So like I tried to explain to guys on ExcelMale is, yeah, there are things that decrease your sex hormone binding globulin, but they're not healthy. As you can tell, the body actually has ways to modulate free testosterone with sex hormone binding globulin. And sometimes it does not make sense to most people that you can decrease sex hormone binding globulin is actually decreased with health conditions as listed here. And what happens to testosterone once it's produced, and the average production in males is 5 to 7 milligrams per day from mostly the testicles. It's converted into dihydrotestosterone, DHT, by an enzyme called 5-alpha reductase. That DHT portion actually is being linked to libido. It's also been linked to the negative side effects like acne. There's still controversial data on whether or not it increases prostate hyperplasia or inflammation of prostate. Actually, it's data that shows that that's not the case. And DHT works on the androgen receptor. The next portion or fraction is a direct effect of free testosterone on androgen receptors. And that effect basically works on the muscle and brain, cognitive function, etc. And the third, which is very misunderstood, I'll be speaking about estradiol in the next lecture because it's a really wide topic with a lot of misconception. I think it's the highest, the most misunderstood hormone in males. Estradiol is produced by the aromatization in the liver and in fat cells too. Of testosterone. So testosterone really is a precursor of estradiol. And estradiol is not an evil hormone. It's actually being associated with increased bone density, increased libido, believe it or not, decreased fat mass, and even cognitive function and improved lipids. So estradiol really is a very important hormone for not only women, but men. And like men with very low estradiol usually complain of low libido, hair issues, like brittle hair, cognitive issues, and bone loss. You can see, I forgot to say, there's a drug up here called finasteride that is used, branded as Propecia or Prostar, that blocks DHT. And lots of data is basically we're getting data from different studies about this finasteride syndrome that has been associated with the use of this drug to prevent hair loss or prevent BPH, benign prostatic hyperplasia. And those men, many men tend to feel their libido has decreased dramatically. Anastrozole and tamoxifen are also drugs used to modulate estradiol, and actually, in my opinion, they're overused in the field right now. And many men are having basically crash estradiol levels that actually have implications in their health. So what are the actions? Testosterone has two different types of actions: the androgenic actions, which are related to binding to the androgen receptor, as I said before, and the non-androgenic actions that are really mediated through the aromatization of testosterone to estradiol, which is very important not only, as I said, for libido and body composition and cardiovascular health, but also it serves also as a feedback signal to in the HPTA to reduce testosterone levels when estradiol is high too. And this is a very common question, and I really think that if you have low testosterone, you should at least consider this before you decide to go on treatment, because it is a commitment to get on a treatment that will shut down your own production. And eventually, if you do want to stop it, it will take a while for you to come back to that baseline. But the first important factor, probably the most important one, is the sleep quality and hygiene. And we all know that we're sleeping less. We are using electronics, like reading our emails in bed. I have to say I'm one of them too, trying to really fight that bad habit, because it really affects not only the production of melatonin and all the other hormones that are produced through our circadian rhythm at night. And obviously, young men are using a lot of electronics, playing games or watching TV from bed, and the exposure of that light late at night, it's really affecting their hormones. So if you try to sleep at least 7 hours a night, get darkness, I'll speak a little bit about sleep, believe it or not, because I really believe is one of the main reasons we're seeing so many young men having low testosterone, which is pretty surprising. Weight loss also, if you're overweight, your testosterone may be down by 100 to 150 points, nanograms. So weight loss is another way to increase testosterone if you are overweight. Avoiding environmental toxins, and that's, as we know, it's very difficult to do in this world, but at least avoiding exposure of food to plastics, especially heating plastics in food, like plastic containers. I'll be speaking a little bit of these toxins too that we have all over, and they're actually becoming more persistent in our world. If you have problems with glucose control, diabetes or high glucose, you will tend to have lower testosterone. So that's an exercise can actually improve glucose control and also improve, obviously, body composition. Exercise actually helps too, but overtraining or over-exercising may actually decrease testosterone. So you have to be careful about that too. And a very important note, there's not an effective over-the-counter testosterone booster. It's a multi-million industry. People are wasting a lot of their money on these boosters in different, obviously over-the-counter and Amazon. And believe it or not, some of them have been found to have Viagra or Cialis. And men tend to feel like, oh, okay, it's working because I have more, my erectile function is better. But the fact is that the FDA catches companies every week. You can go to the FDA.gov site and search for testosterone supplements that are basically shut down by the FDA when they do testing, which is rare because the supplement company is not regulated by the FDA, and they do not have to submit quality control or ingredient testing to the FDA, unlike drugs and medications. So I'm bringing up sleep again, because sleep, I really think, is where we can do our best to increase testosterone. Not only testosterone, really everything, growth hormone, even thyroid function, everything is tied to sleep. And there are things that are good and things that keeps you awake. Anything that, when you go to bed, try to go to bed at the same time every day. Don't watch TV before bed. Stay hydrated. Try to relax and not, get on the phone and have an argument before going to bed. Spend time in the daylight when you wake up and in the morning. Try to get some sun, at least in your face. Read a book. Don't read a book from your phone or from your iPad. Have a light dinner, not too late, and don't do the things below. Don't go to bed and get up at the same time every day. Don't watch TV before bed. Stay hydrated, etc., etc. So try to at least follow the one tip, which is do not bring electronics to bed. And do not expose your eyes to light before 11, after 11, 10:30 to 11 p.m. And try to go to bed at the same time and get up at the same time. But that's obviously easier said than done in today's world. And there are endocrine disruptors, pollutants and toxins that are affecting hormone levels, increasing estrogens and decreasing testosterone in males in particular. And they're everywhere. Flame retardants. They're obviously emissions from refineries, phytoestrogens that even soy products have been linked to that. Hydrocarbons, pesticides, et cetera, et cetera. So that's something else that we need to be aware of. So what are the symptoms? More specific are delayed sexual development for if you're a teenage boy or young male and you see that you don't have any pubic hair or you're having more fat mass, your body is not really developing as a male in male characteristics. There may be something there. Reduce sexual desire and activity, decrease spontaneous erections, morning time erections. That's one of the first symptoms. Gynecomastia, and especially with low testosterone, loss of body hair, pubic hair, very small or shrinking testicles, inability to father children, height loss, low trauma fracture, low body mass, bone mass density too, body weight too. I'm sorry, BMD. Hot flashes and sweats in men. Less specific symptoms are decreased energy, motivation, feeling sad or blue, poor concentration, memory, sleep disturbances, increased sleepiness, mild anemia, reduced muscle, and increased fat and weight, and diminished physical and work performance. And I wanted to show this because there are many factors that influence sexual desire or libido, and testosterone is just one of them, low testosterone. That's why it's important to show this, because many men out there think that by just injecting or testosterone or using a gel or whatever, they'll have increased libido right away. And the fact is that there's so many other factors. Sometimes it amazes me that when we do have, when we feel aroused and even having a child, a very strong erections, how many factors are involved in that physiology. And low testosterone is one of them. Stress, medications can have influence, like blood pressure, antidepressants, statins can have issues there, but we have to take those medications. Even, in my case, I've been HIV positive for 34 years, and some of the medications can also affect desire. So there's certain medications that we just have to take to improve our lifespan, but may influence desire. High prolactin, which can be produced by adenomas, pituitary tumors, organ failure, liver obviously issues, excessive use of alcohol and drugs, surgery can obviously, for different reasons, high cholesterol, heart disease, obesity, high blood pressure, diabetes, and sleep issues and injuries can cause that. So, and also obviously the attractiveness or attraction to your partner too. So obviously that's not listed here, but that's a psychological aspect of low desire. So testosterone is not a magic bullet. It's just one of the factors that can improve libido, but not the only one. So that's something that I know it sounds basic, but you'll be amazed how many men are really get really depressed when they see that sometimes testosterone is not the magic bullet they expected it to be. And the causes of hypogonadism could be chronic liver disease, COPD, sleep apnea, renal disease, use of different drugs, like I said before, glucocorticoids, opiates, ketoconazole, which is an antifungal, and anabolic steroids can actually shut down testosterone production. HIV, hypertension, lipids, infertility, obesity, sleep apnea, arthritis, diabetes, and pituitary adenomas. I'll explain later on what that means. Genetic mutations, and there are some genetic mutations that can affect development, sexual development in boys. As I said before, environmental factors, metabolic syndrome, illnesses, aging, other hormone deficiencies. Thyroid is one of them, very connected to testosterone production. Nutrient deficiencies, as I said before, lifestyle issues, medications. And this is actually a slide that I got from SpectraCell, a very good company in Houston that tests micronutrient levels in lymphocytes, not in actual blood, but in lymphocytes, which is supposed to be more precise. But these are, I'm not saying, this graph doesn't say that adding these vitamins actually improves testosterone blood levels. It may do so, or they may do so only if you have a deficiency, but zinc is definitely good data, magnesium, vitamin E, vitamin K, vitamin D, vitamin B6, and folate. But if you do supplement and you have no deficiencies, you will not see any improvements in testosterone. That's as simple as that. And the benefits of testosterone therapy is probably now evident from all the other slides that I've covered. Improved cognitive function, mood, libido, stamina, believe it or not, improved cardiovascular health. Actually, men with low testosterone tend to die of heart disease faster than men with normal testosterone. There's obviously controversial data right now that has been discussed a lot in the past 3 years on the use of higher doses and poorly managed testosterone therapy that has been associated with increased cardiovascular risk. Improvements in body composition, glucose control, fertility. When you improve testosterone, you can improve fertility to a certain point, and then you may have a decrease in fertility depending on different factors. Exercise functional capacity improves, and there's some studies, not too many, very small data set that may suggest that improved longevity and survival. So how long does it take to see benefits? And that's another one of those questions that we get a lot on ExcelMale. And obviously, it's hard to predict. Everybody's different. Depends on your age. Depends on comorbidities. If you have diabetes, if you have high blood pressure. If you're 29 compared to a 65-year-old, obviously there are different conditions and different factors that are involved in the efficacy of testosterone. But and you see here the different colors. The blue lines say maximum benefits are reached, and on the bottom you see weeks, and the darker green is the upper, and the lighter green is the lower side of the lower duration of when benefits are reached. I'm sorry. So inflammation decreases, testosterone replacement decreases inflammation very fast within 3 to 12 weeks. Blood sugar control, anywhere from 12 weeks on the lower side to 52 weeks. Bone mineral density takes a long time because obviously bone is a lot harder to build. It's a very slow process. Body composition up to 52 weeks. Depressive mood, it could be anywhere from as fast as 3 weeks to as low as 30 weeks. Quality of life could be also, you can see benefits within a few weeks. And that's usually what happens. Men tend to feel really well, really good the first month, and then it tends to plateau, and they get very discouraged after a while. But in most men, like me, that have been using it forever, we wake up to the fact that it's actually improving our quality of life. If we ever run out of testosterone, we stop for any reason out of our control. That's when we really are, awakened to the fact that our quality of life, we have reached a new normal that we forget about. Erections and ejaculations, that is difficult to assess. Some men do experience better erections, especially morning time erections. And some men don't. So it also depends on age and different factors that we really don't know all the factors involved. And sexual interests is probably the factor that improves the fastest and the most obvious. Within 3 to 6 weeks, there's more interest in sex or more attraction to potential sexual partners. There's more interest in general to approach or proceed to have sex or masturbate That's one of the first symptoms. If that's not improved, there's definitely something going on that your doctor needs to look at. The potential risks, this is, I talked about all the beautiful things, and now obviously not everything is perfect and not everything is beautiful, especially if done poorly or poorly managed. Some men, especially younger men, may have increased acne, oily skin, even folliculitis. I'm seeing a lot of folliculitis, which is really a response of the immune system on hair follicles. It has nothing to do with acne, but you know, the same treatments work for acne and folliculitis. When men use higher doses, their good cholesterol tends to go down, HDL cholesterol. The main side effect of testosterone is the increased red blood cells that can increase the viscosity of the blood. And that's probably, I would say, the most common one. Some men need to donate blood every few months to decrease red blood cells or decrease those. Gynecomastia is really rare when you have normal levels of testosterone. It usually happens when your testosterone to estradiol ratio is low. Could also happen due to genetics and IGF-1 high levels. So it's a very complex topic that I'll speak about in the next lecture, because there are many factors involved, and men tend to associate testosterone with increased breast tissue when they start feeling nipple sensitivity, which has nothing to do with gynecomastia. They start freaking out. They think it's all about the high estradiol. As I said, that's a topic that we'll speak about next time. Increased male pattern balding, especially for men, younger men, and it's also there are genetic factors involved there, but DHT may be a factor involved here. Induce or worsen sleep apnea, especially in men that already have it or that are overweight. And there's also a possible increase in cardiovascular disease, like I said before. That's currently being debated. There are actually a lot more studies showing that normalizing testosterone improves cardiovascular health. And only 3 studies showed there was an increased risk. And when they were reviewed, they were found to not be very good studies at all, because they were not monitoring patients properly or providing them phlebotomies to decrease red blood cells. To be honest with you, I'm yet to see a study, believe it or not, in 2018 that actually follows men on testosterone replacement and provides and compares the ones that have phlebotomies or blood donations to those that do not. And all the studies that I've seen so far do not include that, which is the main factor involved in cardiovascular risk, in my opinion. Reduced sperm production and fertility, that's definitely an issue, especially once the HPTA axis is shut down. FSH is actually 0, and there's no signal to the testicles to produce sperm. That doesn't mean that some men on testosterone replacement may not father a child, but as I said, there's the reduction in risk, and there are ways to increase sperm production and quality. I'll speak about HCG on the next lecture on side effect management. So that's not even as recently as 3 years ago, doctors would make men stop testosterone replacement if they wanted to father a child. And now we can actually at least combine testosterone with HCG or use Clomid to improve sperm count and not having to crash your testosterone because your doctor thinks that you should stop to increase your sperm production. There's also controversy when it comes to data on worsening of benign prostatic hypertrophy or even urinary tract symptoms. Most studies published in the past 2 years show that actually an improvement in urinary tract symptoms. Anxiety, yes, I didn't believe this because I actually, when I started testosterone, I felt better, I felt happier. Obviously, I had a chronic illness that was about to kill me. But I see a lot of men on ExcelMale, I don't say a lot, but men on ExcelMale and complaining of anxiety once they start testosterone, and it tends to normalize later or when they reduce doses. Water retention is also very, another one of the side effects that very few people talk about. And there is increasing water retention in the first month or so, an increase that tends to normalize after a few weeks. There are many hypotheses on why that happens, and I will be covering the side effect management topic in part 2, and maybe in 2 weeks or so. The contraindications: who should not be given testosterone, even if they have low testosterone. And the first one is men with severe sleep apnea. They're not currently treated with a CPAP machine, a breathing machine. And believe it or not, a lot of men out there are not tested for sleep apnea. Sleep apnea, in my point of view, is one of the most common problems that we're having out there. It may or may not have anything to do with body weight. In some cases, central sleep apnea is actually hereditary. But it's if you feel fatigued in the morning, even if your testosterone is low, you can blame testosterone for that. But if you're not sleeping well, if you have sleep apnea, obviously your testosterone is going to be low. Another sign that you may have sleep apnea, obviously besides snoring, and your partner may be able to tell you if you are or if you're not, or waking up in the middle of the night, kind of out of breath or with night sweats, is red blood cells. Men or women, obviously, with sleep apnea tend to have decreased oxygen levels at night, and the body overcompensates by producing more red blood cells. So if you see somebody with higher red blood cells, higher than normal, and they're not even on testosterone, that's a pretty good indication that may be the case. So a sleep study is the only way to diagnose sleep apnea, and it's covered by insurance. Hematocrit over 50, which is the amount of red blood cells in the blood. And some men may have actually high hematocrit before they even start testosterone. Those are usually the ones that have recently used anabolic steroids, or as I said, have sleep apnea, or smokers, or COPD, or may actually have a family history of congenital polycythemia, which is high hematocrit, or lung disease. So that has to be explored before starting somebody on testosterone, because if somebody has already a high hematocrit at baseline, it's only going to get worse as time goes by. Prostatic specific antigen also of 4 or higher. Doctors that provide testosterone at that level are liable. There's medical liability there, and it's definitely something that needs to be looked at. Usually doctors tend to send patients to a neurologist for a workup if they're close to 4 before they treat them with testosterone. So when it comes to PSA and prostate, seems to be a concern, although we have more and more data. Dr. Kara here in Houston gave a lecture with me maybe 2 or 3 months ago, and he showed us all the data that he has now proving that in general testosterone does not really cause prostatic cancer, and actually there's a saturation model in which there's a certain amount of testosterone that can accelerate prostate cancer in men that already have prostate cancer, but there is a certain level, higher level, where that no longer occurs. So I'm not going to get into that discussion because it really is something that I'd like him to do maybe a webinar with me about. But men with prior history of prostate cancer that has been successfully treated with complete removal of the prostate and whose PSA is normal or low, don't have to be excluded from treatment from TRT. Those that have gotten radiation or other therapies may actually have some risks involved, and that's something that only a neurologist can assess. If the PSA velocity or the increases by more than 1 nanogram per milliliter, or the patient in the first 6 months, especially, something is going to happen when it comes to PSA. It will happen in the first 6 months. So it's actually a good thing that to catch early on by week 6 or 8 or so. Believe it or not, one of the main reasons for prostatic PSA increases is actually prostatitis or infection of the prostate. Especially when men start having more sex because they obviously have higher libido, they may be more at risk of prostatic infection. So by treating the infection, PSA can calm down. So I tell men not to really freak out too much, and before they go into even biopsies or so. I would not go into a prostate biopsy without at least trying a round of antibiotics to make sure it's not a potential UTI or even prostatic infection. If the PSA does not decrease after 4 weeks of antibiotic treatment, obviously a referral to urology is required, and TRT cessations should be discussed with the patient. The FDA also has been sent a warning to inform men with prior history of clotting disorders like DVT that may have relapse on testosterone replacement. It seems like only 2% of men may have genetic mutations that make them more prone to having clotting disorders. And it's a very controversial topic. I have an interview with Dr. Globulin on ExcelMale.com. He's the expert looking at these different genetic mutations and tests that can be done in men that may be more prone for DVT. And the ones that have DVT, if they're on blood thinners, they may or may not be able to prevent clotting disorders with testosterone. So that's a very controversial issue that I have to say needs to be settled. Although many studies, not studies, but actually reviews have found no association between testosterone and clotting disorders. Testosterone is not contraindicated for obese patients and those with a history of cardiovascular disease at all, even though some doctors think that that's the case. For patients that are overweight, they may aromatize more to estradiol, and they may actually eventually lose fat on testosterone, which may improve their aromatization. But as I said, they may also have sleep apnea and other conditions. The clotting disorder issues, as I said, if you can read it here, there's actually information on ExcelMale.com on how to contact Dr. Globulin for testing if you suspect that you're one of those men and the 2% that may have genetic influences for clotting disorders. So diagnosis, I'm going to go through really fast because we already have spent a lot of time, and I apologize for this, but testosterone is very variable. One test should not be definite for diagnosis because variability is high. So it's always good to run 2 morning time fasting tests of testosterone if you have low testosterone. And there's a lot of variability. Fasting is recommended since insulin can temporarily decrease testosterone. Insulin goes up when you have breakfast. So before 8 a.m., before 9 a.m. on an empty stomach is recommended. There are 2 types of low testosterone hypogonadism, primary and secondary. And they're caused by different issues. The primary could be related to Klinefelter's syndrome, which is a genetic mutation in 1 in 500 to 1,000 newborn males, or testicular failure. And the secondary is more related to pituitary disease, adenomas, hemochromatosis, high prolactin, and drug use, chronic liver disease, etc. So primary hypogonadism basically is diagnosed when we see high luteinizing hormone and low testosterone, which is basically a testicular dysfunction level issue. The pituitary dysfunction issue is usually shown by lower levels of LH and FSH and lower levels of testosterone. Both of these types of hypogonadism are treated the same way, basically with testosterone replacement, but it's always good to find out where your hypogonadism comes from. So as I said before, this is primary is basically coming from testosterone from testicular dysfunction. LH and FSH goes up, which are the signals from the pituitary gland that keep sending higher signals for your testicles to wake up, but they're not waking up. And for the secondary hypogonadism, which is at the level of the hypothalamus, the hypothalamus is actually not sending enough signals to the pituitary gland due to different issues. And so LH and FSH goes down, and so does testosterone. And these pituitary adenomas sometimes are just benign tumors in the pituitary gland that can be diagnosed only with an MRI. And sometimes when you have very low testosterone, under 200 or so, and your doctor has done all the workup and he or she cannot really find where you have such low testosterone, they may send you to get an MRI. And believe it or not, there are different types of tumors. Some of them produce prolactin or growth hormone or excess thyroid stimulating hormone or excess FSH or LH. And most of them, especially the prolactin ones, reduce testosterone by a lot. And once they find out if you have one of these, they can actually treat that issue. Prolactin, there's actually a prolactin blocker that can be used. Surgery usually is not required unless you're already having symptoms like visual issues or headaches, or et cetera. But this is really, really rare. And most of them are benign. So, and they're mostly suspect in men that have this very low testosterone without any other reason. So we're getting into the fun part, and I'm sorry that I'm going over time, but hey, I cut it down as much as I could, but I know this is probably what most of you guys are online waiting for, the treatments. First of all, these are my opinions, obviously, and these are things I've learned after being around for 30 years talking to men using testosterone. But they're top 10 mistakes that I see men making on testosterone replacement. Spending money on testosterone boosters over the counter, as I said before. Giving up too soon when it comes to product choice. Sometimes you are put on a gel or a cream and it doesn't work, so you stop and that's it. You say, hey, this is not going to work. You don't even try other options like injections, etc. Wrong dosing, that's probably the most common. I'm finding out many clinics, and especially HMOs, etc., do not monitor men at week 6 or 8 to adjust the dose. So they send them home with a prescription and that's it. And that's really unfortunate. The fourth is not knowing how to prevent or manage side effects, that's for sure. The fifth, use of black market hormones from steroid dealers. You never know what you're getting. 6, inadequate communication with physicians. That's a skill that you have to develop. Having patience, since physicians are really busy people. And even the ones that they're working in cash clinics, they tend to have a little more time. But testosterone replacement should not be a cookie cutter kind of therapy. It should be customized to the patients. And some physicians are just doing it a little too standard for everybody. And the way you talk to the doctor really determines the relationship you're going to have with him or her and what you're going to get from him or her, to be honest with you. Unrealistic expectations, thinking that testosterone is going to cure everything from libido to erectile function, etc. Forgetting about the effect of other hormones like thyroid. I'm surprised that many doctors do not check thyroid function. They only check TSH, which is not good enough for determining thyroid function. Bad lifestyle choices, excess alcohol, as I said, poor sleep, et cetera, et cetera. And also not choosing the right doctor. And that's a hard one because, and that's probably one of the main reasons men join ExcelMale on some of my Facebook groups, because they're looking for a doctor that can treat them and can treat them well and not treat them like, as I said, with a cookie cutter approach. That's probably the hardest one to find, and the only way to find out is through networking with other patients. That's why it's good for you to be online, talking to other people. Testosterone is a Drug Enforcement Agency Schedule III drug. Is highly regulated. obviously as an anabolic steroid. Testosterone is an anabolic steroid. Testosterone is a molecule that were actually modified to create different anabolic steroids, and higher concentrations, higher injection doses obviously are known to increase lean body mass. There is some controversial data that really has not ever been proven to be right about mood disorders or aggressiveness. And obviously, when you say the word testosterone in this world, that's what is equated to aggressiveness or high risk behaviors. So it is extremely regulated. Doctors have to have a DEA license, and the DEA keeps a close eye on how many prescriptions sometimes they're prescribing, although, as I said, it is an approved therapy that is paid by insurance in most cases. So it is highly regulated. So some doctors may actually be conservative and not want to prescribe much of it or under-prescribe it, even when you need it. So what are the most common prescribed forms of testosterone replacement? The main one is gels, 70% here. That's the first line therapy here in the United States. I'll go through different options. Injectables, even though they're becoming more and more popular, even though they're not as practical as gels, obviously, some men tend to feel much better with injections. Patches, they're not as popular as they used to be, and others, and you'll see what others mean soon, are only 3%. So these are some of the FDA-approved testosterone replacement products in the United States, and obviously it all changes depending on the country you're in. But we have Testim, 1%, which is a gel that was approved a few years ago. You see next to it depo-testosterone. It's an injectable cypionate. I'll be, by the way, speaking about all this, so don't worry too much about me going through the whole thing so fast. Striant is actually an adhesive vocal testosterone delivery system that you put on your gums twice a day. Axiron is another gel that is actually applied on the on their armpits, believe it or not. There's a good reason why too. Testosterone enanthate injections. Androderm is a patch. It's not very popular anymore. Testopel, you can see in the middle, is a pellet. For Testa, it's another gel that is 2% too. And Androgel, which is the most popular of all, is probably the highest prescription numbers come from the Androgel, 1.62%. I'm sorry, 1.62, yes. In the newest testosterone products, there's a long-acting injection called Avid, which is testosterone on the canoate. It's been approved around the world many years before the United States, and it's called Nebido in overseas. There is also Natesto, which is a nasal gel that you squirt twice a day on your nostrils. By the way, I've tried all of these options, and I can speak from my own personal experience. Injectables, they're different esters. I'll explain what an ester is: cypionate, enanthate, propionate, and obviously Avid, which is on the canoate, now available in the States too. Sustanon 250 is not approved in the US. It's an old ester combination that is approved basically in every other country except the US. It's a combo of 4 different esters for a total of 250 milligrams. And it comes in ampules. Unfortunately, when it comes, since it comes in ampules, you have to use the entire ampule in one injection, unless you want to risk infections due to contamination. So that's a drawback there, and it's not, as I said, available in the United States. There is also a product that is under review. It's a subcutaneous, under the skin testosterone injection, which is called the Quick Shot by Antares. They have been sent to the drawing board again, I have to say. The FDA is getting tougher and tougher, approving options that are pretty, this is pretty brainless. I mean, it is testosterone cypionate, which is already approved, provided in an injector for men that want to inject under the skin. But they've had issues trying to get approved. But as I said, it's a company that got smart and said, hey, why don't we provide something that helps injecting under our skin? And I'm going to be showing why that's actually not a bad idea, since it's less painful. And this is a busy table. It's probably the most important table of the webinar. And by the way, thank you so much, all of you guys, for staying with me after an hour. I'll promise that I'm done. I'm not going to take too much longer, but it'll be worth your while, I hope. So let's bear with me, because this is actually very important. These are the different products, as I said before, the gels, androgels, 1%, or you can get 1.62% for Testa, Axiron, Testim, and compounded creams that are made by compounding pharmacies. And they're, as you can tell, they're the dose regimens. And I'm not going to go through all this, otherwise we'll be here all night. But you can obviously, when you get the video, you can pause this slide and look at it more details. And there are advantages and disadvantages of gels. The advantages is that, they work quickly. The physiologic pattern of blood levels is more stable. The easy self-administration every day after a shower. Compounded creams are actually not alcohol-based, and they can be applied to the scrotum for some men that need more DHT for improved libido. The disadvantages is that sometimes there are insurance issues. The insurance companies are kind of playing a game right now, where they come up with deals with different companies, so they only pay for a certain product and not for others. So it really is not your doctor's decision, but their decision instead of your doctor's. There's possible site irritation, although that's very rare. There's a transference risk from men to women or kids, so that's very important. If you're going to use gels or creams, do not do it in the morning, and if you have sex with your wife, do it at night. At least wait 12 hours. If you're holding a child, just make sure you're not exposing the kid to testosterone transference. But there's also unreliable absorption, and some men, for some reason, do not feel or do not see their blood levels raising much more than 600 nanograms or so. The oral vocal Striant is really not popular because you have to use it twice a day, and there's a risk of transference if you kiss your partner. And it's not, I haven't tried that one, to be honest with you. That's the only one I haven't tried for obvious reasons. Twice a day is really an issue for me. Injections are shorter acting than antheta and cypionate. They come in 200 milligrams per mil or 100 milligrams per mil. And advantages, they're inexpensive, the oldest treatment. The disadvantages could be high blood levels, peaks and valleys, and may cause higher hematocrit, red blood cell production. Avid, the long-acting testosterone decanoate, the advantages is more stable and less frequent injections, better compliance, obviously, because of that. But there's a large injection volume, and you have to go to a doctor to get an injection every 10 weeks after the initial 2 injections in the first month. And there's this rare post-injection cough that could happen too. The pellets, Testopel is the approved compound, approved product in the United States, commercially available, 75 milligrams per pellet. Compounded pharmacies actually make more concentrated pellets, 100 to 200 milligrams, and a lot cheaper too. Obviously, Testopel can be paid by insurance, but to be honest with you, a lot of men have to pay out of pocket, even with insurance, a lot of money, because they need a lot more pellets, and the insurance companies are willing to pay. So Testopel, 16 pellets every 3 to 4 months, and compounded pharmacy pellets, 6 pellets, since they're more concentrated. The advantage is long duration, stable levels, better compliance, and the disadvantages is there is actually, you need to have a procedure to get the pellets inserted under the skin. I'll show some pictures later on. The pellets can pop out if the insertion was not properly done. Bruising and infection also are factors there, depending on the insertion methods. Patches are, as I said, not as popular, and androderm, 2 to 4 milligrams. Men don't like them because obviously the disclosure issue of having somebody ask you why you have that patch. Obviously, you can say you're trying to stop smoking, but that's not. The disclosure is really a big issue, and some skin irritation. And nasal testo, as I said before, is a gel. I did use it. It gave me a headache because it increases your blood levels pretty high, pretty fast. It's twice a day. Gave me sinus congestion, and I just didn't like the sinusy kind of side effects. But it does increase testosterone quickly, and some guys seem to like it. Transdermal, the products that we apply under skin. So I'm gonna try to go really fast on this. The application sites, and why are these application sites the ones to use? There's only one reason, because those are the application sites that were used in the studies. So the FDA only approves things that are used in the study. And yes, in the gels and creams can be, absorbed in other areas, like, in the inner thigh. Axiron, for instance, uses the armpits so that you don't have to transfer testosterone to your female partner or to kids. And gels, you definitely provide more stable blood levels than injections. This is the graph for androgel. But an issue that really is really disturbing and puzzling is there's a review of 15,000 hypogonadal men. These are prescription numbers. This review does not provide the reasons why they stopped. They didn't get a refill. And they followed this man from 2009 for 12 months. And as you can tell, and these are, the different colors are different doses of, this is androgel and testim. And as months went by, more and more men drop out of treatment. Obviously, these are prescription numbers, so we don't know the reasons. I can speculate that poor monitoring, because that's really a #1 problem that we're seeing, that doctors are not following up these patients after 6 to 8 weeks to readjust the dose. They don't explain the different side effects or the different expectations. So I don't think this is all due to the fact that men don't like gels. I think it's mostly some issues related to monitoring, but I'm obviously speculating. So androgel, these are doses. I'm not going to go through this since we had some of this info on the table, but Axiron is very interesting. Axiron, the company said, well, let's minimize the transference to women and kids by making this product that you can apply to the armpits. So interesting concept. And this is for Testa, which is a 2% gel cream that you put basically on the inner side of your thighs. This is the Axiron, the one you apply on your armpits. And as I said, it's always good to monitor blood levels. Anything above 500 is good. And obviously, the higher the blood levels of testosterone, the higher the risk of increased red blood cells. So that's something that to keep in mind. The test for a gel or cream should be done 6 to 8 hours after application. And obviously, if the blood levels are lower than expected at week 6 or 8, increase the dose. The disadvantages is consistent absorption. It has to, patients have to be taught how to apply correctly. There's a sticky feeling on skin in some cases. Some of them are pretty clean. Testim has an odor. I don't particularly like it. Skin irritation is rare. Risk of interpersonal transfer and variable blood levels really are, for some reason, some men absorb testosterone from gels better than others. The adhesive buccal striant is put on the gums twice a day. There's some gum irritation, alters sense of taste, and it's not very popular at all. And how about compounded testosterone therapy options made by compounding pharmacies that are a lot cheaper and in many cases, more concentrated than the commercially available products. You obviously have a testosterone cream, which is a cream, not a gel. It's not based on alcohol-based, like the androgel or Testium. There's a testosterone cypionate injection, 200 milligrams per mil, testosterone enanthate, propionate, which is a shorter acting testosterone. It's not very popular, but some men seem to like the shorter. You have to inject it more frequently. Excuse me, I need to drink some water. Anastrozole, which is an oral estrogen blocker, Clomid or clomiphene to improve fertility and also to treat younger men too. HCG, which I have a whole lecture on HCG and to improve testicular size and fertility, using it with or without testosterone. Excuse me. And you see these little vials here. These are actually pellets. Compounded pellets that are used subcutaneously to increase testosterone, and they only need to be applied every 2 to 3 months. And compounding pharmacies are like pharmaceutical companies, are smaller. Some of them are family owned, some of them are bigger corporations. And there are two types, and most patients don't know that, and it's important to know because this industry is changing rapidly. There's a 503A compounding pharmacies and 503Bs outsourcing facilities. The 503Bs have the same requirements as pharmaceutical companies. When it comes to sterility, they have to spend a lot of money on fancy equipment to make sure that, especially injectables, are completely clean and safe. And a lot of the 503As now cannot produce injectable products like they used to just 2 or 3 years ago. So the industry is changing. A lot of companies are out of business now. Only the ones that have a lot of money and can start from scratch. This is actually a picture of me with my friend Sean Norian from Empower Pharmacy when I visited his facilities, and he made me wear one of those spacesuits to go inside the sterility room that is positive pressure and all that. So it's kind of fancy. Why use injectable testosterone? It is cheaper, although some men have good insurance that basically with low copays for the commercial available injectables. But they use grapeseed oil sometimes that is less viscous, and some guys seem to like it for subcutaneous injections. They're shipped directly to patient with all the supplies, all the syringes, so you don't have to worry about that. It's really low cost. It costs less than, basically less than $30 a month to use injectables. Sometimes that's even cheaper than copays. And excuse me, the FDA regulations are really new regulations that have popped up. Probably making 50% of companies be either out of business or having a reduced scope on where they can ship and what they can ship to other states. Also for women, compounding pharmacies are key because there's no FDA-approved testosterone product for women, and the only way women can access testosterone is through compounding pharmacy creams, and also other blends with progesterone or estrogen, etc. So there are different, obviously, brand names of testosterone, like I said before, but insurance companies are making deals with these companies so that they give preference on one brand over the other. Copays are an issue, obviously. Insurance companies are actually determining who needs testosterone, who doesn't, not the doctor, and that's very disturbing. And also compounded products can be produced at higher concentrations like pellets or creams than the regular commercial available products. Dosing when it comes to injections like cypionate or enanthate, 100 milligrams per week or 50 milligrams twice per week are common nowadays. Believe it or not, there are many doctors still prescribing 200 milligrams every 2 weeks, which I'm going to show why that's not really a smart idea, even though it's what has been used for years. Checking your total testosterone, your free testosterone, to make sure it's at least above 500 to 600. The highest dose is 250 milligrams a week anything higher than that is considered an anabolic steroid dose. We're no longer using the huge needles. We're using small needles. I'll show you guys some pictures on that. The compounded creams are also, as I said, are cheaper, and the creams are alcohol-based. They can be up to 20% of testosterone, and you can make higher concentrations. 60-day supply is around $50, etc. So I'm going to move on a little faster so that you guys can move on with your night, right? And I still have all of you online right now, so I appreciate that. As I said, there are different doses here, so I'm going to just move on this slide. Injectable testosterones, excuse me. There are esters like N-theanine and cypionate, a shorter acting propionate. Disadvantages, there are peaks and valleys, and you can decrease them by more frequently injections with lower doses. That's becoming very, very popular, especially in the cash-based clinics. The old school was to prescribe 200 to 250 milligrams intramuscular deep injections every 2 weeks. The new school thought is 100 milligrams every week or 50 milligrams twice a week. We're seeing not only better efficacy, but lower hematocrit, lower production of red blood cells, and side effects by doing that. This is the old school dosing that has been used for the past 30 years or 40 years in this country, 200 milligrams of N-theanine or cypionate every 2 weeks. And what happens, as you can tell, is that you peak testosterone, obviously, in the first few days, and then you go back down by day 14. And DHT also peaks, and estradiol also peaks and then goes down. So many doctors have basically been prescribing instead weekly administration of 100 or every 2 weeks, twice a week administration of 50 to 75, so that we minimize these peaks and valleys of blood levels. So what are esters? Why, and what is the cypionate, N-theanine, all this stuff? What happens is that unmodified testosterone has a half-life of 10 minutes. That's how long it takes for the liver to completely get rid of the testosterone molecule. So chemists, basically the 30s and 40s, basically 30s, attached little molecules on the what we call esterification at position 17. You see the testosterone molecule here, and then you start seeing all the different esters, propionate and thiocyanate, with little attachments that are a lot longer than the OH that you see on position 17 here on the testosterone. Methyl testosterone, by the way, is an oral that is no longer used because of liver toxicity. So by modifying the molecule, it makes the body not dispose of metabolized testosterone as fast. So it gives the body, the product, more chance to work. So that's why it's called esters. I don't see some people think N-theanine lasts longer than cypionate in the body. Really, we have seen no data to prove that. Propionate is definitely shorter acting, needs to be injected more frequently than testosterone, cypionate, or N-theanine. And on the canoate, which is here on the bottom, is the longer acting one that can last anywhere from 8 to 12 weeks max. The company says longer than that, but I've seen data that doesn't really justify that. Okay, so there's esters. They were basically modifications to the molecule so that the liver does not get rid of testosterone so quickly. So the most commonly used injectable regimens, every 200 milligrams every 2 weeks. It is really what the package insert of commercial products say, but in many doctors that are not really that well educated are still using that dose. And I'm not saying that's a wrong thing to do, because the companies are actually telling the doctors to use that for commercial products. But 100 to 200 milligrams every week is getting more and more popular and common. And for men that are really highly adherent, highly compliant, and a lot of the men on ExcelMale are. It's amazing how, so many even inject every day propionate because they say they feel better. So it really takes a lot of commitment, but and a personality type for that. But I'm seeing it done. So I inject myself 75 milligrams twice a week with an insulin syringe. I'll show you a picture of that I took of myself. The testosterone is not available in the United States every 2 weeks. The Libido overseas is 1,000 milligrams every 10 weeks, but in the US, it was approved at 750 milligrams at week 0, 4, and then every 10 weeks, 750 milligrams. So monitoring is important in checking testosterone levels. Peak testosterone 24 to 48 hours after injections. Most doctors don't do that. They actually have you check your testosterone right before the next injection for the lowest possible level. The dose needs to be increased is your blood testosterone at week 6 or 8 has not reached levels above 600 or so. If you decrease the dose and inject more frequently, you decrease the chances for peaks and valleys. So this is actually the injection techniques. You'll find some of these kind of interesting, hopefully. There's their old school of thought, intramuscular injections, IM, deep IM. We used to use 1.5 needle, 23 gauge to inject in the glutes, in the butt. That's how I did it for, I don't know, 15 years. And I didn't know there was any other way because that's what I was told back when I didn't know any better. The subcutaneous injections have been shown in the past 4 or 5 years to work really well, as well or better than intramuscular. And the shallow IM is a term that I created because that's what I do. I use shallow IM. I don't like subcutaneous injections under the skin because they cause me to have redness, and I don't like redness on my abdominal area. So the then and now. Then, back in the days, and as I said, I used this technique for years. We used to have an 18 gauge, a big gauge, to load the testosterone inside the syringe, then switch the needle, because once it goes through a stopper, it becomes a little dull. We switched it to a 23 gauge for injection. So you have to use basically 2 needles and 1 injection syringe. Obviously, 23 gauge in the butt. It didn't hurt too much, but I have to say I wasn't looking forward to it every 2 weeks like I used to inject back in the days. But I had a problem 3-4 years ago. I had a neurological issue, and I hate to talk about my own health, but sometimes people don't understand how experimentation occurs. And in my case, it was the fact that I lost a lot of the function of my right hand. So I only really have a good hand, my left hand, to inject. And I said, well, when am I going to do that? I don't want to depend on anybody. Some men depend on their wives or girlfriends or boyfriends to get the injection, but I really think you should be independent. So I said, well, I have to find a way to inject with one hand. And 27, and I tried all the different gauges. 27 gauge, 1/2 inch syringe takes a while to load, but it really does not take more than a minute and a half to load 50 milligrams to 75 milligrams. Less pain. You don't have to use a loading syringe. You waste less product. People forget that when we use a bigger needle, bigger syringe, you tend to lose some testosterone in the tip, on the base of the needle. You see it here in the picture. There's the blue plastic area here on the bigger needle. So we basically are wasting less testosterone. We have fewer supplies, good penetration. We have good data now. Only one hand needed, no aspiration. That's the best part, because the deep IM injections in the glutes or quads needed aspiration to make sure you didn't hit a vein or an artery or whatever. And the 1/2 inch tiny needle, very subcutaneously or even shallow IM on the delts like I use, have very little chance for issues like that to happen. So that removes that requirement. But however, I do advise that injecting more than 0.5 cc's with an insulin syringe tends to create a large volume under the skin or shallow IM that may create some scar tissue if you abuse it. So shallow IM, the deltoids, quads, and glutes can be used, subcutaneous abdominal area. A lot of guys are using subcutaneous injections. The best data we have on efficacy, believe it or not, we have there was a study published 8 months ago or so in transgender female to males using the subcutaneous method, and the study showed really good blood levels with that method. So that's where we get the data from, believe it or not. The sites, as I said before, the delts, glutes, upper gluteus area, the quads, obviously the shallow AM on the delts, and subcutaneous. So things have changed. I think the subcutaneous and shallow AM with an insulin syringe has made things a lot easier for many of us. I really don't feel pain at all. And it's so much easier, and especially when it comes to supplies. I'm going to skip on that because we already heard that. The pellets, yes. We're approaching the end. I know you guys have been very patient. Testosterone pellet, Testopel is the commercially available product, 75 milligrams per pellet, 12 to 16 pellets every 3 to 4 months, depending also on the lowest T level prior to the next insertion. Some insurance companies pay for it, but they only pay for 6. So you have to pay out of pocket for the rest, and it's pretty expensive. Compounder pellets are obviously, as I said before, a lot cheaper. They can make 100 to 200 milligrams per pellet, 4 to 6 pellets every 3 to 4 months. And I don't know what the total cost is, to be honest with you, but I know that it's at least a third to 20% of what Testopel is out of pocket. So they're tiny little. They look like rice, like little rice. It has an excellent profile. There's a need, obviously, for insertion. Pellet extrusion can happen in 10% of patients where the pellets pop out when the doctor does not do it right. Infection and bruising can happen also due to bad insertion technique, and that's you have to make sure the doctor that is going to provide the pellets knows what he's doing or she's doing. It's important to measure blood levels of testosterone before the next insertion, because not everybody can wait for 3 months to get the next insertion because your blood levels are too low. And not going to go through all the details on the insertion procedure, but basically it's right here by the upper glutes, and they actually insert the pellets with a trocar with forceps, and they push a few of them. And I've gotten this done, by the way, and it wasn't painful at all. And you don't feel them. They feel like little tiny rice pellets under your skin, and they dissolve slowly with time. And you don't even know they're there. But I've seen, obviously, some cases where guys are not as lucky. As you can tell on the left-hand side, there's, in this case, it's bruising. And, you know, it doesn't mean that the insertion technique was not good. This person could have been on blood thinners or aspirin, et cetera, but it could also be insertion technique. On the right-hand side, that's what it should look like if done properly. So really quick, I'm not going, this is what clinical and medical groups say that you have to do when you monitor blood testosterone replacement. You know, the DRE, digital rectal exam for prostate, I'm not going to go through all this, as you can tell. It's just to let you know they're 1, 2, 3, 4. They don't agree on everything. Or they don't even agree on when to measure testosterone levels. They kind of agree on when to measure hematocrit, which is a proportion of, oh, there's a misspelling there too, sorry. There's a proportion of red blood cells in the blood. They kind of agree on that every 3 to 6 months. Bone mineral density, most doctors don't check that unless you're old and you're having fracture issues. Lipids, only one mentions lipids, which is, you know, at week 6 to 12. But most doctors I know in the field, in the cash clinics and even insurance, are more aggressive than this, than what guidelines suggest. They do follow up, they do a baseline, then follow up at week 8, then another one at week either 12 or 16, 6 months, and then once a year if you're stable and your dose is optimized. And initial blood tests, you know, total free testosterone, PSA, LH, FSH, lipids, CMP, CBC, sensitive estradiol, by the way. That's something I'm going to speak about next time. And the estradiol test has to be done using the sensitive test. And if you have very low testosterone at baseline, you should check your prolactin, or you could do prolactin right away if you want to spend more money doing that. You can get a blood test done at discounterlabs.com. Doctors can also sign up to 4pmd.com if they want to join a group of doctors and get a discounted price for their patients. So as I said, 6 weeks to 8 weeks of follow-up. Believe it or not, there are doctors that don't do follow-ups, 6 months follow-ups, and then annually if the patient is stable. And another very important slide that I will not go into details, I'll do this next time for the side effect management, but every single variable on the left-hand side and be managed in doing different ways. So you can either choose to pause the video when I send it out to review this, or wait for the next lecture, which will be really in detail about every single one of these factors and how to monitor and stay on top of it. My 10 TRT commandments: have reasonable expectations. Do not fall prey to testosterone booster scams. Do not obsess about estradiol without testing it and testing it with the right test. I'll speak about what that means in the next one. Monitor your hematocrit, because really red blood cells increases are the #1 side effect, and that can increase blood pressure and headaches and cardiovascular risks. Explore easier ways to inject, like subcutaneous or shallow IM. 6, never cycle testosterone on and off. There's no such a thing as cycling testosterone replacement. You'll actually do more harm than good, because when you get off, you'll have low testosterone for a few weeks. You cannot change what you don't measure, so monitor your blood tests. Know your trends. Use my health graphs and the TRT Analyzer app. Do not change more than one variable at a time. You will lose track of what works and what doesn't. That's something I see all the time, guys going crazy on what works, and they change so many variables they don't really know at the end what happened. Protect your fertility and testicles and upstream hormones with the use of HCG. I'll be speaking about that too later on the next lecture. And don't stay behind. There's a lot of information coming through that if you don't stay on top of it, if you trust your doctor to keep you up to speed, then you will have some problems if your doctor. Obviously, this is a lot of information at this point of the lecture, but I will speak about it in the next lecture on the different steps of doctors. And this is more for doctors, since the lectures that we create at Clinic Optimizers is to train new doctors on how to follow patients. We have process charts like this one I created for the intake process, different factors that need to, and laboratory testing that needs to be performed when you walk in, then the first visit, the general algorithm, 4 weeks later and 8 weeks later, and also a general flow chart depending on different issues that may pop up throughout the process. There are different, and we are almost at the end, guys, so I appreciate your hanging on. I've only lost one of you, so thank you. Adjunctive therapies that doctors prescribe with testosterone, as I said, anastrozole and others, HCG. Many doctors are starting to prescribe IV or injectable vitamins and nutrients, growth hormone releasing hormones, oral injectables, ED drugs, obviously Cialis, Viagra, all that can be also obtained cheaply from compounding pharmacies. Oxandrolone and nandrolone, there are actually 2 anabolic steroids approved in the United States for different conditions. Metformin, which is an anti-diabetic drug that is becoming more popular due to potential life extension benefits and also even weight loss, and blood pressure medications, among others. And this is it. This is the last one, believe it or not. TRT resources, my site, obviously. peaktestosterone.com is another site that is great. I forgot to really mention, I was supposed to dedicate this presentation to my good friend, Kurt Meyer, who founded peaktestosterone.com much before I founded ExcelMale.com. He unfortunately died in a car accident 3 months ago. He was a very close friend, and he was a pioneer. He created a lot of the information we rely on right now. 10 years ago, a very good guy. He was even, people didn't know even his real name. He's known as Lee Meyer online. He has a book on Amazon, Natural versus Testosterone Treatment. So Google it, because it's a very good book. You can obviously get my book for free, as I said, from the first link I provided, The Testosterone Man's Guide. And his book, Lee Meyer's book, Natural versus Testosterone Therapy, thick. It's like 300 pages, but the guy really goes into details with questions from that he collected throughout the years. For physicians, they can join a lab group. These kind of labs to get your own blood tests, my health graphs, as I said before, and TRT Analyzer. And Power Pharmacy obviously have strong biases for them, since they're in Houston, and my best friends owns it, and they have great quality, and they are a 503B FDA inspected and regulated company that spend a lot of money qualifying for the new requirements. So that's it. That really is. I appreciate you guys hanging on. I went, even though I tried to go fast, as you can tell, even a basic part 1 lecture on testosterone is a long one. So I do appreciate everybody's patience. The next webinar will be about management of potential side effects and risks of testosterone therapy. I'll be sending out an email. If you register for this webinar today, you will be getting an alert when the next one is up. So thanks a lot. Not gonna take questions. You can obviously ask questions on ExcelMale.com. I show you all the folders depending on the question. You can even mention my name if you want me to answer the question, since I have, they're easily 25 guys that are super smart there, plus at least 5 doctors too. So if you have, I'll be posting this video on YouTube, and I'll be posting also the video on ExcelMale.com. So you can also post your question right below the video posting. So thank you very much. Appreciate your patience, as I said, and stay tuned for the next one. All right. Good night. You guys take care. Bye-bye.